Good afternoon, good afternoon. Good afternoon, Varelio. Bonjour, Vasilio. Ça va? So nice to meet you all. Let me take this opportunity to invite you to this very important session as far as the maternal, newborn, and child health is concerned. This is one of the SDGs. And majority of the countries around the globe that are off track to achieving the Sustainable Development Goal number 3, which is to have maternal mortality less than 70 per 100,000 live births. On our side, I think we have made some progress, but still we are a bit behind. Hopefully, when the official statistics will be out, then we might be comfortable to come forward and share with you what progress we have made so far. So, as you can see, the topic of today is about collaboration across ministries for successful innovation, adoption, and system change. And the M-Mama system is one of the innovations that came into being as a result of collaboration. Collaboration within the government system, but collaboration within the private sector, and so is a public-private partnership. So for me, I'm very, very much delighted to be moderating this session, because M-Mama is close to my heart, and I've witnessed so much with M-Mama. So as the panelists for this session, these are the wonderful individuals from different ministries, government departments. So without further ado, let me take this opportunity to invite over Dorolosa to take a seat. Dorolosa is the country director for M-Mama from Vodafone Foundation. Then next is my brother, Ahmad Makwani. He doesn't need any introduction. Yeah, he doesn't need any introduction. It's enough to say he's one of our very resourceful persons as far as the maternal, newborn, child and adolescent health is concerned in the country. Then Makwani is working with the Ministry of Health. He's directing one of the directors at the ministry, which is responsible for the maternal and child health. Then I have an honor to invite Daniel Salungi from the Ministry of ICT. He's quite very young, but very resourceful. He has done a lot in the ICT space, so we are very happy to have him with us today. Then next is Mariana from the Ministry of Finance. She is also from the ICT department, very experienced. And as you can see, the panel, we tried to make sure that the gender is well considered. This is different from other panels which we have been to. And then we have our colleagues from Zanzibar, and we have Dr. Salim Slim. He's a director of preventive services. And we have, so Dr. Salim Slim, can you stand up and wave? He's quite a very resourceful person, and he has been one of the very instruments as far as the M-Mama is concerned. Then we have my sister, Dr. Fatma Kabole. Very resourceful indeed. And then we have Dr. Farid from Zanzibar. Yes. So we shall have some stories from the colleagues who are here up front, and from there then We shall invite Dr. Fatma to give us the experience from Zanzibar. So without wasting any further time, let me take this opportunity to start shooting these experts' questions. And I'll make sure that I suffocate them. So Dolorosa, you just tell us a bit about the mama. For some of us who are not familiar with a mama, what is a mama? What is it all about?
Thank you, moderator. Hi, everyone. Thank you for coming. We really appreciate your time. Karibuni sana. So, M-Mama is an emergency transportation system for maternal and newborn, actually for pregnant mothers at any time from conception until they deliver their babies, and then for postpartum mothers under 42 days and for neonates under 28 days. And actually, why M-Mama? M-Mama is there to reduce maternal and neonatal mortalities. And actually, it's done through strengthening the referral and emergency transportation system. As we all know, I can see most of the people who are here are from Tanzania. So we really understand the number of ambulances that we have, number of public ambulances. So now M-Mama comes in to bring alternative transportation. Actually, it's not, the referral system is there, but then it's strengthening the referral system. So we have this number of ambulances, but when ambulances are not available, we are using community transport, or the owners of vehicles in different villages who are identified and then trained, and then they enter MOU with every council to provide the service. So M-Mama is strengthening that system by technology, and then at the same time also providing alternative transport when ambulances are not available. So this M-Mama, I believe most of us have had M-Mama after presidential launch last year, but M-Mama has a very long history, actually over 10 years. Since 2011, that's when the ideation started, 2012, and then 2013, that's when the first phase started. And it started actually in 2 different councils. One was Sengerema District Council in Mwanza, and then Sengerema, of course, later on was divided into Sengerema and Buchosa, and then there was Shinyanga District Council. So we started with 2 councils from 2013 to 2017. At that time, we were really trying different interventions. The program M-Mama was called MMHO, Mobilizing Maternal Health. And we dealt comprehensively in all 3, we can say, delays. And in delay number 1, we worked with community health workers across all those councils. We had 2 community health workers in each village. They were trained and they were visiting every household to actually register every pregnant woman. And then we also did another intervention, which was maternity waiting homes in Sengerema and Shinyanga. And then we had this M-Mama, which is the emergency transportation system. And also in the 3rd delay, we built a number of actually NICUs and maternal, what do we call that? Remind me of the names, actually in delay number 3 for quality of health. Okay. Yeah, so we built several theaters actually. I meant maternity theaters. And that was actually, yes, yeah, in different wards. So in general, that was phase 1. But phase 2 now, 2017 to 2021, that's when we started real M-Mama. And because different, research were done at that time with MUHAS, with Mackenzie, and then in all those researches, they just realized M-Mama, how the emergency maternal and neonatal emergency transportation system was more effective in terms of cost, in terms of affordability, in terms of government being able to sustain it. And also the major thing also at that time was about the impact, in reduction of maternal mortality, because it's proved to reduce maternal mortality by 38% and neonatal mortality by over 47%. So in that case, they advised that we should move on with M-Mama now, the emergency transportation system. So phase 2 was all about emergency transportation system, which is M-Mama now, until 2021. And now, last year, 2022, that's when Her Excellency, the President of Tanzania, Samia Suluhu Hassan, officially launched M-Mama in Dodoma last year. That's when everyone started hearing about M-Mama, and she directed us to ensure that M-Mama is scaled up across Tanzania mainland and Tanzania Zanzibar. And just in 1 minute, Mr. Moderator, can we just look at can you just watch a video that speaks about M-Mama by Her Excellency?
Okay, thank you very much, Dorosa, and I think now we are ready to watch that short clip. Dr. Fatma, can you come over to sit?
5 wanapata dharura zinazohitaji usafiri kwenda kwenye vituo vinavyotoa huduma stahiki ili kusaidiwa. Serikali kwa kushirikiana na washirika wa maendeleo ilizindua. Ndugu wa Tanzania, kila mwaka katika nchi yetu akina mama patao milioni 2,370,000 wanajifungua. Kati yao 45,000 wanapata dharura zinazohitaji usafiri kwenda kwenye vituo vinavyotoa huduma stahiki ili kusaidiwa. Serikali kwa kushirikiana na washirika wa maendeleo ilizindua mpango wa M-Mama mwanzoni mwa mwaka 2022 ikitaka kuhakikisha wanawake hawa na watoto wao wanapata usafiri wanapokuwa katika hali ya dharura ili maisha yao yasiwe hatarini. Dira na maono yetu ni kuwa M-Mama ipatikane kwa kila mama mjamzito katika mikoa yote ya Jamhuri ya Muungano wa Tanzania kabla ya mwezi Oktoba mwaka huu wa 2023. Inatia moyo sana kuona kwa utekelezaji huo unaendelea vizuri. Kuongezeka kwa matumizi ya simu za mkononi pamoja na maendeleo ya teknolojia nchini Tanzania kunatoa fursa kubwa ya kuimarisha utoaji huduma katika sekta mbalimbali ikiwemo sekta ya afya. Nchi nyingi katika ukanda wa Mashariki na Kusini mwa Afrika zinajifunza mpango huu kutoka kwetu na zimeanza kutekeleza M-Mama katika nchi.
So, thank you very much. I think Her Excellency said it all. So this is one of the very important initiatives, and we are very happy really to see that M-Mama now is across the country, meaning Tanzania mainland and Zanzibar. That's why we are also graced to have Dr. Fatma in our panel. She'll also give us the Zanzibar experience. Now next we go to Dr. Makuani to describe the current referral pathways and emergency transportation system in Tanzania. Dr. Makuani, karibu.
First of all, I should thank our colleagues for organizing this panel, because in M-Mama we have a lot of stories to tell, but I'm inclined to talk about the pathway of referral system in Tanzania. I would like to repeat again the word that the moderator said earlier. If there is one of the projects whereby even if you wake up at night and then you are asked, what can you say about M-Mama? This is one of the projects whereby most of us, we don't need scripts to go through, because we have been part of the process, part of the development, part of the expansion, and part of implementation. Referral system for maternal and newborn in Tanzania. When we look at the policy perspective, first of all, you have that organogram of healthcare system, whereby you start from the community, you go to a nearby dispensary, you go to health center, a district hospital, then you find the regional referral hospital, then you have those zone and specialty hospitals. I'll try to navigate through it. By giving some of lively examples, because a mama we are using, it has helped a lot of bringing the country together. If a patient, if a mother is having complications, say in the community, whether she is in pregnancy or she is in labor or she has delivered but she developed some complications, she will definitely move to a nearby health facility. And if we go through the script, that may be within the catchment is a dispensary, it's more likely. And the expectation is they will go through these hierarchies. But in our guideline in emergency, it says the one who is referring that patient should correlate the condition of the patient vis-a-vis the services which are provided in various levels. What does it mean? It says, for example, if you know exactly the way I see this complication, if this patient sending to that dispensary will not suffice, and if you have a bigger hospital nearby, you can move directly to that hospital. But if there is no facility like that, then you go to a dispensary. And if the dispensary they find this complication, going to health center may be causing a delay, you better move straight to district hospital or referral hospital. That script is there in our emergency referrals. Now, but usually the biggest gap with the communication. That has been our biggest gap. And I would say when I came into office, the first thing I did, I started the WhatsApp groups. And we have I have almost like 14 WhatsApp groups, whereby I see various services throughout Tanzania. Even some few minutes ago, I was looking to one of the groups and I was seeing how they were managing one of the patients. My colleague says, well, they are doing that. These groups have connected the big experts, professors, around the country. They are able to provide services. But when it came the mMama, it assisted us a lot because of one value. First of all, it uses the governance structure. Because if the RMO in a region is connected to mMama and his or her team, they can see how the patient is coming, say, from community or from a dispensary to another health center, or from a health center going upwards. Again, we said we need to put a dispatcher at the regional referral hospital. The regional now becomes a controller of the entire region, because, in facility, if you are high up, you are automatically the mentor of the lower facility. So now the regional referral hospital, they will be overseeing the facilities below it, how they perform. And there are critical decisions. I saw some critical decisions out of mMama in Arusha, critical decisions which were made in Lindi, whereby they were seeing every time certain referrals, when they are coming from one point, they had some difficulties. So they went to mentor them and support them. So, in essence, I would say, with mMama, it has unified the referral system. That does not mean we don't have challenges. When you develop, or when you want to reach point X, you start with step 1. And I would say, by having this unification system, whereby we are able to see various referrals, for example, myself, I'm one of the subscribers. In my office, when I have time, I can just pop in and see countrywide which region is having movement. Then I can, sometimes if I have time, I can post, I say, do you see that patient is coming to facility? So and so, are you prepared? And they feedback, they say, yes, we are prepared with that patient, and we know that patient is coming. So that's how the referral system is working. But we have some challenges, of course. This system is using, majority of the referral is using the government ambulances. But we have community drivers. And those community drivers, they need to be remunerated. That is an area that possibly in a course of this discussion, you will see how better we have used them and what are the difficulties that we have encountered and how we have managed to mitigate them through. But because of time, maybe I go back to...
And that brings me to Daniel to explain to us how Mama works electronically. Please.
Thank you. So as we have heard our colleagues here, that mMama is emergency medical transport system for maternal and newborns. In the technology perspective, mMama is more than a system. mMama is a technology, we can say, is like a technology stack that includes various technologies put together to provide a solution. Some of the technologies that are put together to have mMama as a solution working, one of them include the mobile technology, because mMama can be operated through the mobile app, that where the dispatchers get the interface to interact with the system. And the mobile part, again, it has the intelligence that we call like a brain of the mMama, which we call it a triage. Triage analyzes the type of emergency, and it also, it can identify, according to this type of emergency, where the treatment can be provided. So the triage can direct like this emergency needs to go to which facility for treatment. So that is the brain of the mMama itself as well. But another technology includes the web technology. We know about the web technology because it's integrated to web-based services as well. But we have some big data in the system. And this is where we apply the business intelligence and analytics with massive data of that we are gathering through the emergency transport system as well, all together. Then we produce massive data, and with this business intelligence analytics, we can provide and we can share dashboards that have meaningful for decision making as well. Another technology is data synchronization. Now we know that this is actually in many parts of the Africa, that internet itself is not that much sustainable, and availability rate sometimes make it difficult to operate when something's depending on the internet for 100%. So mMama has this the data synchronization technology that allows mMama to operate offline. So whenever there is no internet or there is a fiber cut, the service will still be available, and when the internet comes back, the data will synchronize to the central storage system as well. But again, we have integrated Google Map engine for routing, because through the mMama, when the driver takes an emergency, then the system directs like what path to use to reach the destination or the higher health facility according to the referral details. So that we have integrated that with Google Map engine for routing, and it has the capability of offline as well. And another, we have integrated it also the FinTech. FinTech is financial technology, because the drivers are getting paid through the mobile phones. So there are some aspects of financial technology that later on we will describe, and we'll see like how it works. And then We have also the technology to identify the location of the caller. Whenever we see there is an emergency, then maybe the call is made like 115. The system will identify like the source of this call is in where. So it will direct the call to the nearby dispatch center to get service as well. And then we have the shared help desk facility. This is a park whereby, you know, Mama it has a very special care in Tanzania, as we have seen how it emerged and from the directive of the Madam President, Her Excellency. So Mama, there are various ministries all together working to make sure that Mama is operating successful. So even the help desk technology that we are using, it cut across all the ministries. So even if it's on the financial, maybe there is any financial thing that needs assistance, the Ministry of Finance will work on it. If there is any technology part or compliance or standard or wherever, the government will take part of this. If there is any maybe communication breakdown, the Minister of ICT will take that part. The Minister of PRAG, President's Office, Regional and Local Government as well, the business owner and the Minister of Health. So all working together through the help desk that is working too.
Thank you very much. And the good thing with Mama, it has a potential to generate big data that will enable us to come up with artificial intelligence solutions. So there's a lot of opportunities as far as the Mama's system is concerned. Now that brings me to Mariana to give us her experience on the finance space.
Thank you so much, Mr. Moderator. Good evening, all. First of all, I would like to appreciate and congratulate all who have played a role in the success of Mama, because it has been really a life-touching and life-saving system. So congratulate all. And talking of the payment system, how it is being done, the payment process starts when when the driver is being called. That's when the recording of the information starts in the Mama system. So it will in the Mama system, it will be recorded who has been called, what is the destination point, what is the departure point. We'll keep all the records. And before then, after keeping that information, the payment would be done manually. But we thought of how can the payment be done in more speed, to increase the speed of payment. So we integrated the Mama system with the government accounting system. It is called the MUSE. MUSE is the short of Mfumo wa Uhasibu Serikalini. So the Mama system has been integrated with MUSE. So after receiving the information from the Mama, the information gets into MUSE system for payment processing. MUSE system is also integrated with banks. So after the payment processing in the MUSE system, the information goes to bank, and the bank will do the payment to the drivers. Now the drivers are being paid either in their mobile phones or in their bank accounts, anyhow that the specific driver prefers to be paid. So, and that has been very convenient to them, because like a driver is paid 30,000, paid in somebody else will just prefer to be paying in the mobile, because it is more convenient, get it on time, and it is also less cost, because there won't be a cost of going maybe to the ATM machine or going to the bank to do the withdrawal. So it has really been convenient to them. So, and the flow of the payment from the Mama system to the bank to the mobile, it is very traceable, in the system. So can trace when it was that done, who has done it, all sorts of things. So in short, Mr. Moderator, that's how I would say about the payment.
Thank you very much indeed. And I must say that Mama revolutionized the payment system in the government. Now even the community healthcare workers shall be using a similar arrangement for the payment, because there's a lot of transparency, accountability, and those to mention few, but also we are moving from papers to paperless payments. So with that type of system, surely then we shall be moving into the digital era at a speed which is of the light. So let me take this opportunity now to invite our colleague, Dr. Fatma Kabole from Zanzibar. So we have had a lot of conversation from the Tanzania mainland. Now let us go to Zanzibar so that we can have a Zanzibar experience, the land of spices.
Oh yeah. Thank you, Dr. Ntuli. I'll start from there. Those who know me, they know I hate microphones and podiums. And I have to say, but when he told me that I have to give that experience, I didn't hesitate, because this is one of the things, the innovations which works. And I would like to thank Dolorosa personally and Vodacom Foundation, as well as Meshach and Pathfinder and Touch Foundation. These guys have actually been holding our hands through the rollout of M-Mama in Zanzibar. This lady right here, mpaka alijua kufuga kilemba kuliko navyojua mimi. She has been there holding our hand through the thick and thin. Tumeenda kote. I would be mixing English and Swahili, but please, asante sana. I do, yes. And that's how I communicate. So, Dolorosa, we thank you from the bottom of our hearts. You with your team, as well as our friends from TAMISEMI, they have been there. Anytime the system checks, you just get a call and say, Yamani, system imegoma. The next thing is they are there. So that's the dedication we have from the team right here. And we thank all of you for that, as well as our partners. So Zanzibar people, when we talk about Zanzibar, they think of spices and the beautiful islands and the beautiful people like us. So, but we are actually islands, and we have 53 of those. So that's the challenge which we have with M-Mama. We rolled out M-Mama in December. That's when we went live, and we have saved 2,000 lives. That's not a small thing. We have not had deaths of a mother or a child through that innovation, and that's why it's very close to my heart. But as I said, we are islands, and that's where the challenge comes in. We have islands with health facilities, we have islands without health facilities, and with very heavy, choppy water. I leave it to you to think about that. How do we get a mother from an island without a facility to the water to take her across? And when you take her across, you have to transport her to the facility, which might not be very near. So that's the challenge which we have, but we are trying, and we urge partners here to help us, because for us it's not just the community drivers, it's the community boats. And as I said, we are 53 islands. That's for you to think about. And I'll end there. Thank you very much.
Asante sana, my friend Fatma, and I really appreciate. And first of all, for the compliments which you gave to my colleagues, we really appreciate. And I must commend the Zanzibar team that we didn't have a lot of challenges when it came to roll out of the ongoing life for M-Mama in Zanzibar. So congratulations to Zanzibar. Now, let me go back to Dr. Makwani. What are the gaps now when it comes to the refill on the emergencies? You spoke a little bit about that, but what are still existing gaps as far as the M-Mama system is concerned?
I'm not going to be very far from what she said. Yet Tanzania is a diverse country. Just across here, we have mafia, for example. You have places like in Ngorongoro. We have places like in Mlimba. I tell you, those are difficult places. One of the nights I remember it was in Ngorongoro. They shared one of the patients and they wanted to transport. And we thought as if that patient was not ideal to be dealt in that area and had to be moved to Mount Meru or KCMC. And somebody answered me, Dr. Makwani, but do you know where is the Ngorongoro and how to get there? He was right. It was just the next morning that we got the flight from Tanapa, that patient had to be flown from Ngorongoro to airstrip in Moshi, just to find out she had acute renal failure. She survived, fortunately. But quite often I have an experience of seeing patients. Pwani region extends to Mafia. And to transport a patient from there to mainland here, it takes about 3 hours. They go to Delta in Utete. Yes. And from there, it takes about 150 Ks to move by road. Another 3 or so hours to Dar es Salaam. Through our communication, I've witnessed some of the women who died in the boat, and the boat had to return to. So, for me, I have started strongly to advocate we should not think only for vehicle transport and boat ambulances. It is high time now we start addressing within the mfumo, within the system, to have air ambulances. And here, there are countless places, Mlimba. So this is a difficult area for referral system in Tanzania currently. Geographical diversity of the country. The country is huge, and referral system does not end in district hospital or regional hospitals. Sometimes we bring patients up to JKCI. JKCI people are in various groups of the WhatsApps. And they instruct there and then they say, now the patient has to come to JKCI because we can't offer more than that. So I would say that is the obstacle number one that I think we need to address to make sure we galvanize very well with our mfumo and mama. Secondly, you know this distributional curve. There are those people easier to change. It's about change of the behavior, okay? Yesterday I witnessed some of the group. They reported there is a patient, and then a person in the regional referral hospital is complaining, but we don't see that patient in the M-MAMA system. That patient is not reflected in the M-MAMA system. So there was a lot of discussion there that we need to assist to change practice and attitude, saying that reporting in the system was very, very helpful. For example, I just learned today that the good thing in the system in Dar es Salaam is that police, fire brigade, health system have been connected together in the M-MAM. So if the patient is coming from say, Tandika, or say patient is coming from Bagala, all these systems are informed and the road is cleared for them to pass. So this is the issue of change of practice and attitude is extremely important to ensure that we get the potential of the use of the system. Because there are those who have accepted to use the system, but yet we have those who are falling outside the cave of normal cave. Those ones, and I don't know which side is skewed, whether those who do it more better or those who don't do better. So we need to see how best we can bring everyone into the cave, making sure that they can support the system. Number 3.
A minute?
Yes. Number 3, currently we are having some challenge, Mama, in the uptake of community. And the fear, I would say we are worried what would happen if the community takes over. And the issue here is cost. And I think as we are moving forward, we need to allay that anxiety so that it reaches a point whereby from Kinondoni, if a mother is starting to labor there, if she wants to go to say to Mwananyamala, she can make a call from home and then she can get integrated into the system. So that is a challenge. Those are the challenges that I see we still need to make, but as we have made a step. We are not starting from scratches. We have made a step and I'm sure we can move forward. I submit.
Thank you very much. And from there then, I'll ask Dr. Ross and Dr. Fatma to present to us what are the options to ensure sustainability of M-Mama system. But before we go into that, I don't know if people can visualize the screen. The beauty of M-Mama, you can have real-time information. What is happening right now across the country? So as you can see there, the system aggregates that on itself. So far we have had about 39,551 emergency transportations. And you can see the number of lives saved to the right-hand side. And this is real time. And if at all there's anything is happening right now, there will be the red spot. You can see those red, these are the live emergencies which are happening right now. So this is apart from saving the mother's children's life, it is an accountability system. You can track back and find out who caused the delay. Within the system, you can conduct an audit trial and know who is responsible for what delay. You know what we have learned in the past, people will fake and say, no, I'm not responsible for this one. But this will tell you, truly, you are supposed to be at this duty station and help this mother, but why didn't you do that? So it's trying to address those 3 delays. The delays of making a decision at the household level, reaching the facility, but receiving the appropriate care at the facility. But the remote triage is what makes this system very unique. Those people who are working at the dispatching center, they'll always call and try to inquire what a woman or a child is presenting with and try to prepare the receiving facility with all the necessary information and to allow them also to prepare necessary inputs for a woman or a child who's coming. So you can see now, there's a live emergency which is happening. You can see a vehicle there. It's happening right now. We need information right now. You cannot make a decision on the information, especially which is life-saving, if you get next morning. But that it will be a bit late. You have already lost the battle. You need the information now. And this is what we are saying. So we thank Her Excellency, Dr. Samia Suluhu Hassan, for championing this. This is massive. This is massive, and people now are flying from all over the world coming to learn what is happening as far as the mama is concerned. Now, Dolorosa, how do we ensure all these efforts are sustained? Then the same question will go to Dr. Fatma. After that, the floor will be open for Q&As.
Okay, thank you, Mr. Moderator. The uniqueness of M-Mama, we started with an end in mind. So from the beginning, from the ideation stage, we started with our colleagues from government. We co-created M-Mama together. That's the first and the secret behind this success. And also we co-funded, jamani, mradi ambao unakuwa co-funded na government. Kwa hiyo, sisi, we were like paying the setup of the system across the country, and the government is doing the running costs. So each facility across the country has put the budget of M-Mama in its own, like the CCHP's comprehensive council budgets. So every facility has to budget for M-Mama, and actually, so every facility is the one that is paying for those drivers. So what we do for us, we do the technology. Of course, now knowledge has been transferred to the government, as Daniel has spoken about. It's fully owned by the government. So what we did was the training and the knowledge transfer, and they did all the work. And in that case, the technology part, maybe Daniel can speak about the sustainability of the tech part. Okay, but then on our side, like really it's just the setup of the system, and running of the system is fully paid by the government.
Thanks. So we pass it to Dr. Fatma. Then Daniel, when the floor is open, any question that will be directed to you, make sure that you include the component of sustenance of this program.
Asante, Dr. Ntuli, as Dolorosa had said, this is purely the government, a partnership between the government and our friends. But for us, if you look at the data, which like I have in my office, the director there has it in his office, and this is the beauty of M-Mama. You get to see and take the decisions as they come in. In Zanzibar, in Unguja, 78% of the referrals are done through ambulances, government ambulances, and that is sustainability from the outset. In Pemba, it's a flip. Most of them are done through the community drivers, and because in Pemba we have more islands. And as I said, we are islands. But the government has committed to increase the number of ambulances in each and every district. And that has already been budgeted for. The ambulances have been bought. And we believe that would reduce, but also the knowledge within the communities to reduce the delays. I believe if we are able to reduce the delays, we would reduce the number of referrals because the women come late. And that is where the trouble begins. So this is for all of us. Jamani, nani kama mama? Nani kama mama? That's your answer, Daktari.
Thank you very much indeed, Ratu. So today I got in the new, so I found a new response now. So it's a baba, eh? Very good. So, ladies and gentlemen, so now the time is yours. Can I see the hands up? Yes, yes. So we start from Seya. Ambrose, do you have any question? Okay, so Seya then Ambrose, then we go to Mariana Balampama.
Asante. My name is Insea Kipiliango. I'm a digital health expert from Inspire Consultant. And I would like to congratulate the team. I know it has been a long journey. And for me, it's more on a comment. Since we have these existing systems, we need to leverage on those existing systems like PlanRep and FARS. And since we are talking about sustainability of this mMama, as Dr. Rosa has mentioned that all these expenses or costs has to be planned for. And by doing that, we have to make sure that in PlanRep, all the issues regarding all referrals in mMama, because you have the cost now, so use the cost to do the budget. So leveraging the use of PlanRep and FARS, I think, be more, appropriate. And yeah, because you've mentioned Muse, but I know Muse is for the central gov, and we are operating at the facility. So we need to use these two systems to do that. And I'm glad to see progress on this. Thank you.
Thank you very much, Insea. Ambrose?
Thank you very much. It's been a learning for me. I got to know about this about 2 months ago, and it sounded like just a project when I met the team at Pathfinder, and today it's actually a government of its own. About 7 years ago, I worked in a regional referral hospital in Uganda, and I was in the charge of theater. So then my theater card for fuel got done. But the ambulance had fuel. Its card was still operational. And I had a mother to operate, but then I had no fuel in the generator. But then the ambulance man said, I have fuel to refer, so do your job. So give me a referral letter and I take the mother somewhere else. But I said I have a theater which just needs light. What is my point is that when we let systems operate individually, we fail to make complete decisions. Because it was very easy for finance to frustrate health, or even IT to frustrate finance for their own reasons and their own mandate. So for somebody to allow a payment to go on through straight, back in Uganda you need a very good paperwork, a requisition, an approval, you put in a payment request, it takes a couple of days, the driver is frustrated, and the system is dead, and the patient is buried. So for me, the exciting thing is that we have these solutions within ourselves. There is no person coming from Oxford to tell you what to do. I believe that health care and our governments in Africa, I work across 8 countries in Africa, I've seen the worst of health systems. The worst. I was in Sierra Leone about just a week before COVID, and I would see mothers die in facilities. I mean, to get an ambulance in that country is like to ask for salvation. It's very complicated. But the issue is that we believe that solutions are out there, when actually they are with us. So the investment in the sectoral coordination and allowing everybody to play their role, I think is the magic of the investment, and this is what I think we need. So for me, just basically a comment, and I hope that you can allow other governments and ministries to learn from this investment, because otherwise there's a huge investment we are doing in different countries, but is ending in procurements of equipment not being used and all that. Now I have a question. If you referred a mother to the referral hospital because of level, but then at the regional referral level you find the emergency section is being managed by an intern doctor who is basically 2 months out of medical school. But when actually the health center, there is a senior medical officer who has failed. We have had those issues. So you are at level 3, you are at a health center, you refer to regional referral, but the receiving doctor is 2 months out of medical school. How do you address that? Thank you.
Thank you, Ambrose. Now we go to Mariana Balampama. Then to
Thank you. My name is Mariana Balampama. I work at PACT as Deputy Regional Director for Africa. This is amazing. Congratulations. So medical emergencies requiring transportation go beyond maternal and child cases. How is a mama currently accommodating other cases that occur within the community? And what are the plans for expansion of this program beyond only maternal and child health cases to involve various medical emergencies occurring at communities? Thanks.
thank you. I led at the back. Then we move to this side.
Thank you very much. My name is Adela Nali from Girl Effect, Tanzania. First and foremost, I need to commend the government of Tanzania and Vodafone Foundation for this initiative. This is really beautiful, especially for many mothers in this room and fathers as well. This is very beautiful, and we are very happy that this initiative is happening in Tanzania and saving the lives of mothers. So my question will be, how do we utilize resources along the way when we're saving a life of a mother? So a mother is encountering a driver. So do we capacitate these drivers on first aid to ensure that they are able to do first aid solutions to the mothers before reaching the hospital? But also, we have seen in so many places that the lives of mothers during childbirth are being saved by people who are not, I wouldn't say non-medical people. So these drivers that we use, do we also utilize their presence during that journey to ensure that they're well capacitated to save a life of a mother, just in case there is an emergency and they need to encounter?
Thank you, Adela. Okay. So, my brother over there? Yes? Then Nyombi.
Yeah, thank you so much. I'm Martin, a medical doctor. I would like to appreciate and thanks so much for this Mama program. Actually, I heard it firstly through Dolorosa. Whenever I come across her, I see Mama. Every time I see Mama. So I really appreciate it for her commitment. My concern is that Marianne have said it, but we are talking of sustainability. And in this, today we are talking of collaboration with other ministries, and this is transdisciplinary approach, which is very important in sustainability. Why? Because we will be getting the cooperation from all other stakeholders. And this means that we have to expand from only maternal and newborn. For example, this newborn will become a young adult or adolescent who is at the risk of getting maybe road traffic accident that needs a very emergency referral. For example, got a traumatic brain injury that needs a CT scan. It needs an urgent referral. We might have saved a newborn, but left him at a young adult. So this needs to be expanded so that we may reach all these groups. Thank you.
Thank you very much, brother. Thank you very much. That's quite very pertinent. Nyombi, Geoffrey. Do you have a question? No. Nyombi.
Good afternoon. My name is Godfrey Nyombi from USAID. I want to plug a pitch and congratulate all the people involved into Mama and encourage more. USAID did this with Vodafone 10 years ago, and today we are here celebrating this innovation. 10 years ago, it was just a small dream, and now it's becoming a reality to what it's doing right now. I'd like to encourage private sector, Vodafone and the like, to continue investing into health. Because this is the future of health financing, this is the future of sustainability, and all questions that are related to improve the quality of care and universal health care as we're talking about it in this summit. I want to encourage the government, using existing government system, innovators within government. We've seen PORA going to Zanzibar. We're sitting aside just watching all of that. It's fun just to see that. It's fun to see the ownership of the government into this. I want to encourage new innovators, young people who are in this room, come up with those ideas. This was once an idea. Today, it's saving lives. So I want to encourage that in the room, so we leave here knowing that there are so many more possibilities, and I'm sure we'll save more lives and we'll reach to the vision of universal health insurance. Thanks.
Thank you very much, Nyombi. So now, it's time for the panelists to respond to the questions. So I will start with Dr. Fatma. Do you have anything to respond?
Please use the mic.
Innovators, because we really need those innovators. How do we, as I said, what kind of boats? We cannot use the normal boats to transport a pregnant mother in labor. We need, what kind of entrapments should be put on the boats? So those are the smaller, innovative things which we are looking at. And again, encourage the innovators. It was said in the opening ceremony. Those are the things we are looking at. Smaller but saving lives.
Thank you very much. My brother Makiwani.
Yeah, I have several remarks to respond to. First one is my colleague here who went to Sierra Leone. And I know Sierra Leone, I worked in that country. What it means in terms of referral. I would say, first of all, that comment you said about what happens if where you want to refer the patient, there is an intern who has just graduated from internship. And if you go back to my background information, the guideline is so clear that you shouldn't refer blindly. You should know where you are going, and you should expect what services are there. But yet, you have a valid comment. In our situation in developing countries, those are real situation on the grounds. But we try to mitigate those challenges. Fortunately, by the time the MMM was coming, there was a high-level commitment using the other system that I talked about. And somehow that one is complementing heavily in exactly where to send the patients. And they had the other initiatives whereby our regional medical officers and district medical officers in their locality, they get, by say 4 hours, they get a report of their locality about the patients. We call it Kanzidata. We started that one, and it tells where there's a patient who needs an immediate support. So bringing these three together, we somehow address that challenge. And then another question was, what happens in referring when there is no skilled profession? So far, 3 out of 4 patients currently which are being referred, they are referred by these ambulances. And within the ambulances, we have again another guideline which provides the referring facility must avail a skilled personnel in case of anything along the way. Of course, we still need to address that challenge when it comes to our community drivers, especially when they will be moving from community to the health facilities. And then the program needs to be expanded. You know, we need to start somewhere. First of all, we should congratulate ourselves that we have started somewhere. And I would say, you know, maternal and child death is a mirror of functioning health system. If you want to mirror your functioning of health system, this is an indicator which anyone, when he looks at it, he says, hey, look here, there's death. It's not acceptable. So when you are fixing it, actually you'll find yourself, you are fixing the entire health system. I worked in Sierra Leone, he's talking about, in 2010, 2011. We fixed the maternal and child death. We found we are fixing everything there in the community. And lastly, it is true, it has been a fun all the time. It has been fun. And I just want to give you, there's a moment where you could see some people having some palpitations when the government was taking the lead. But slowly we massaged them, we said, because the speed was too high that to be accommodated within the space of private practice. It was, the speed was too high. And we had some work with my colleague here to try to massage, calm down. You are okay, you will survive. But we are here and now we are congratulating ourselves saying that we did something very, very valuable for our community and everybody. We congratulate everyone.
Thank you very much. Thank you very much indeed, Dr. Makwani. I think before we proceed, let me acknowledge the presence of my boss, the Deputy Permanent Secretary responsible with Health, Social and Nutrition Services from the President's Office. Please stand up and wave. Then I shall have, yes. His name is Dr. Wilson Charles Mahera, Deputy Permanent Secretary responsible with Health, Social and Nutrition Services from the President's Office. Towards the closing, I shall give him an opportunity to say hello to all of us. Now we proceed with Dolorosa.
Okay. Thank you so much, Mr. Moderator. Na karibu sana mheshimiwa. Okay, so like as Doctor has said, really the secret behind this was actually partnership. Within the government itself, I think so much has been spoken within the inter-ministries, as we've seen, Ministry of Health, Ministry of PORAG, then there is Ministry of Finance. What's your ministry again? Iga is under which ministry? Again, the President's Office, Public Services. So like, you know, there's so many ministries within the government itself. But then, even as partners also, like we've really maintained the same partnership from the beginning, from the ideation stage. So Vodafone and USAID as funders, and then we had our implementing partners, Touch Foundation and Pathfinder International, really from the ideation stage to date. So you can see the secret behind this success is also that leadership and commitment, and also leadership from all levels, from, you know, top number one to the village executive officers, because everyone is involved in M-Mama, and that is the major secret. So responding to the questions, I have, I think, 2 questions to respond to, and responding to the question from the girl from Girl Effect. Actually, let me just quickly explain on how M-Mama works, because I think that will respond to her question. So when an emergency happens, either from the community or from the facility, they call number 115. So currently we have a 3-digit number, which was provided by Ministry of Health. And when they call that number, currently we have dispatch centers across the country, but we have 1 dispatch center per region. And in Zanzibar, we have 1 in Pemba and another 1 in Unguja. Yes, so the calls are picked at the dispatch centers, which are located at our referral regional hospitals. When at the referral regional hospitals or those dispatch centers, we have dedicated supervisors. Okay, we have dispatchers who are trained how to use the M-Mama system. So in that dispatch center, our dispatch centers are very simple. They have like 3 calls, 3 phones, 2 for incoming calls and another 1 for outgoing call. And then they have M-Mama system, which is kwenye kishkwambi. What is kishkwambi in English? Okay, so they're using that kishkwambi to guide them. So when they pick the calls, they actually do the remote triaging to confirm if it's a real emergency and where it should be taken to. because the M-Mama system itself has all the details about the nearby facilities that could provide different services depending on that referral case. And then they also have the list of drivers. First priority are all government ambulances. And then now an alternative driver is called when the ambulance is not available. So the Kishkwambi also has the details of all the community drivers in every village. It's like Uber or Bolt or something, like you have all those drivers who are close by that patient where the call comes from. So after, after confirming or after doing the remote triaging, they also allow, like the dispatch transport, whether an ambulance or the community drivers. So the question that you asked about the drivers, are they trained? Yes. So the dispatchers are trained, the drivers are identified and trained. And also the training also is very comprehensive, and it has different people, including the police, the traffic, who are looking at other legal issues. And then we have the legal officers actually, because they need to sign MOU with the councils, so legal officers of the different councils. And we have Ministry of Health that speaks about, like the first aid and all those things. And they're also provided with some facilities like first aid kit, we can just call it, yeah. So those drivers are trained. And then after that, again, the other important thing that we need to really mention is that the dispatchers have to call the receiving facility to make them prepare. Okay, they have to get prepared for that, yeah. And then, so when the emergency gets into that facility, like the receiving facility is prepared. The other issue that you spoke about, it was about the drivers. Actually, we had the challenge with drivers' payment with all those government bureaucracies, and that's when, like the Ministry of Finance came in to just bring a solution, which is a digital solution. And now the payment system is, it's a digital payment system, and it's connected to government payment systems. Thank you.
But remember, bureaucracy is a necessary evil.
Okay.
Next. Next, Mariana, do you have anything to respond?
Yes, thank you, Mr. Moderator. Just one on the comment which was saying the use of plan rep and pass. I would say yes, these systems are also being used, and the plan rep is a budgeting system that is being used by the agencies and the local governments, and the facility budget is done in plan rep. FARS has been integrated with MUSE, and MUSE is not only for central government. MUSE is also used is being used by the local government authorities, government agencies, and authorities also. So yes, these systems are being used. Thank you, Mr. Moderator.
Thank you very much, Mariana. Daniel?
Thank you so much. To add on top of the comments, the integration is done also, and Mama and FARS are integrated. But we're also planning to include HFR, which is Health Facility Registry, together with NAPA for National Physical Addressing System. And again, on adding on what Ross has commented on whenever the emergency, when emergency is transported to destination, it's not only the driver in the car. There is a nurse from the originated source that is escorting the patient to the destination. So that is for the community drivers as well. So if I come across to the expansion of M-Mama just in a bit, right now
we have 1 minute, please.
Okay, thank you. We are using 115. 115 is for all health emergencies, and we have started with M-Mama. And even the M-Mama system is now as a module in the bigger system, which is emergency medical services. So we have already initiated the expansion to emergency medical services that will cut across all emergencies. But as of now, the M-Mama module is ready up and running, and some of the modules are still on progress. So, because I've just got this opportunity, let me also finalize that M-Mama, this is the first mobile, this is the first tech stack that we have exported out of the country. So we built M-Mama sustainably by the government officials and local innovators, and we've already exported M-Mama. Right now, M-Mama is being used in Lesotho, and M-Mama is also used in Kenya. And very near soon, M-Mama will be launched in Malawi as well. Thank you so much.
Thank you very much. This is a homegrown solution, so we are very, very proud for this one. But we're also grateful to USAID, Vodafone Foundation, different partners with whom we work together to realize this big dream. Can I ask the audience, ladies and gentlemen, were these people met to expectations? Did they? So I think they deserve a round of applause. Hongereni sana. So you can quickly take up your seats while I'm taking this opportunity to invite over my boss, Dr. Wilson Charles Maera, to say hello to you. Dr. Maera, you're warm welcome.
Hello. I greet you in the name of the United Republic of Tanzania. Okay, as the director introduced me to you, my name is Dr. Wilson Mahela Charles, the Deputy Permanent Secretary, PO Large, responsible with the health, social welfare, and nutrition. So first of all, I take this opportunity to thank you for this meeting that we have organized here for 3 days. We started yesterday. Yeah, I was supposed to be here, but due to inevitable circumstances, I could not manage. And this morning, I was supposed to come here early morning, but then my daughter was being operated on at Muhimbili. So they started from around 8 to around 1, but it has been successful. So then I finished that one. I said, let me come and see you. But I must say that the management or the leadership of PO Large appreciates and understands that you are here. And the theme for this year, as you all know in Tanzania, the provision of health services is actually done in a pyramidal, where the primary health care is being supervised, conducted, and run by the PO Large. But when you start from referral, regional hospital and above, is Ministry of Health. And we work very closely with the Ministry of Health as a sector to make sure that we improve the provision of health services in the country. So this meeting is quite relevant. The summit is very relevant, and especially to us, PO Large, because it is in the meeting says strengthening health systems for universal health coverage, focusing on primary health care. And as you all know, almost 85 to 90% of Tanzanians receive services from health services, social welfare services, and nutrition from primary health care. So if you are discussing here on various ways, the strategies to strengthen the provision of services in the primary health care, is something that is in line with our strategic implementation plan. I've seen here that I've also heard that because the issue is we want to improve the quality of the provision of health services in the country. And actually this is in line with also the vision and also the dreams of the President of the United Republic of Tanzania, Dr. Samia Suluhu Hassan. As you all know, that she has done a lot to invest in the infrastructure of health facilities, right from the primary health care to the national. So what we are doing now, though we have invested a lot in the infrastructure, but we still have faced some challenges, especially shortage of staff, but also not really good, some poor provision of health services. But we have some human resource, but that do not. They have been trained, but they still need to have technical capacity, building capacity to them. So when you discuss here for 3 days, I think you are going to come up with some of them, I have seen them here. And I'm sure I've seen also some of our stakeholders that supports us. Because for us, the directorate where Ntuli is the director, we have got almost a strategic implementation plan where we have got strategic objectives. One of the objectives is to make sure that we involve community participation and ownership. And I have seen somewhere here, when you have community participation and ownership, that becomes also somehow sustainable. Again, on the issue of access and the quality of provision of health, social welfare and nutrition, that's one of the second strategic objectives. So while you are here, I must say that I will be here, I think, tomorrow, most of the time. And the Minister of State actually has also given me a task, so I'm going to be with you here, so that the deliberations of these meetings, we're going to make sure that we supervise those deliberations to make sure that they are well implemented to improve the provision of the services of health in this sector of health. And I'm happy to see people here from the Ministry of Health, because we want now to think in terms of sector. So Ministry of Health and the PO Large want to work together to make sure that we support and make sure the Tanzanians receive quality health services. And I know we face also some shortage of financing some of the activities in the health sector. So maybe one of the takeaway from this discussion is that we are going to come up with because we share here, we have got stakeholders. Maybe some of our stakeholders will continue supporting us, because although the government is putting a lot in making sure that we provide good quality services to the Tanzanians, but we still face some shortages of resources. So those stakeholders, I've seen someone from Zanzibar. How are you? Yes. So this actually, this meeting is very relevant. It has brought many people from various places. I must say that I'm looking forward to participating tomorrow. And today, I think I have nothing more to add, but congratulate you for the good job that you are doing.
Thank you very much indeed. We appreciate for remarks which you have given us. Maybe I didn't introduce the audience. So here we have international participants, we have the non-state actors, and we have people from the private sector, as well as the team from Zanzibar. So it's quite a very unique summit. So we are celebrating the 10th anniversary with a very unique participation. So we are very grateful for the team, and we appreciate the Tanzania Summit Secretariat for that. Otherwise, on that note, let me take this opportunity just to sincerely thank each and every one of you for having participated in this wonderful, wonderful session. Then enjoy your evening. Asanteni sana.